Okay, great. I think we are recording, so we can go ahead and get started. Thanks everyone for joining us for the Primary Care Advisory Group meeting this evening. I guess it's getting dark early, so I feel like I can start calling it evening at 5 o'clock. We have a very exciting agenda today, and I will start out kind of with our welcome and introductions. Then I'm going to give you like a quick tour of some of the information that I emailed you ahead of this meeting, and then I'll be handing it over to Dr. Hammery and his team for our main agenda topic today. So as you saw in my email, the main topic today is about our Act 167 community engagement work. I don't want to steal all of Dr. Hammery and his team's thunder in terms of introducing it, but we are very excited that they're here today to talk with you and get your perspectives as primary care providers. We did share the memo that you put together and sent over to Pat Jones. So as Bruce said, for the folks who were here a little early on the meeting, he saw it and is excited to talk with you about a lot of the recommendations that you highlighted, because I think they align really well with the community and provider engagement work that we're doing to think about health system sustainability. So I will start out today though with attendance, and we're gonna as we do attendance, we'd love to have PCAG members just say your name and where you practice, or maybe like a short introduction, just so that Dr. Hammery and his team can hear who all is on the line, and then they'll do their introductions when I hand it over for their presentation. So I have my list here, and I'm trying to kind of connect it with the names I see on the screen, but I'm just going to go alphabetically and we'll see who we get, because not everyone's on my screen. Is Dr. Ramsey, Ellen Ramsey? I didn't see his name pop up yet, I don't think. Okay, we'll keep going down my list. I do see Dr. Wolfman though.
Hi. Hi, I'm Carrie Wolfman. I am a family doctor in Brandon, where I've been in the same office for 25 years, and I'm the Chief Medical Officer at One Care Vermont ACO. Nice to see you.
Perfect, thank you. Sorry, trying to match all my lists with each other. I see Eileen, so I might have you go ahead.
Eileen Murphy, I'm a family nurse practitioner, mostly rural Vermont and in Orange County.
So thank you. Is Dana Kraus on? I don't think, not seeing, okay. Elliot Rubin?
Yeah, hi
Sorry.
everyone.
Oh, you're here, great.
I'm a retired pediatrician after being in practice for 36 years in New Jersey. I went to UVM for medical school and I live in Plymouth, Vermont.
Thank you. And I think I saw Faye earlier. Oh, there you are.
Yeah, I'm here. Hi, Faye Homan. Also rural family medicine. I'm in Wells River and sort of on vacation right now, coming to you from a hotel room in Pennsylvania.
Wow, thank you so much for joining us on your vacation. We appreciate it. Is Katie Marvin on? I don't think so. And what about Lee? I don't think so either. Michelle Wade? Have I seen her? No, I'm just, the alphabetical order is striking out right now. Robert Penny. Oh, Rob, there you are. You want to just come off?
Yeah, I think you missed the intro.
Oh, yeah, we're just saying your name and where you practice briefly to introduce PCAG members to Dr. Hammery and his team.
Oops.
Did we lose him?
I don't think he can get off mute.
Okay.
Yeah, Dr. Penny, you're on mute, I think.
Okay.
We can hear you.
Great.
Okay. Where are you, sir?
Currently in Middlesex.
Ah, thank you.
Great. Thank you for being with us tonight. And I see Tim Tanner is here if you want to say hi.
Hi, I'm Tim Tanner. I'm a med-peds primary care clinician working at the Danville Health Center for 30 years. I'm also the medical director for Northern Counties, which is an FQHC that covers the 3 northeastern counties in Vermont.
Great, thank you.
Great.
Good.
And Valerie, I think I see you.
Yeah, you do. Hi, I'm Valerie Rooney. I'm a pediatrician who practiced in southeastern Vermont for over 30 years in Bellows Falls, which is very rural, and Brattleboro, which is semi-rural. I also teach at Geisel School of Medicine at Dartmouth for the last, well, we've had students in our office for almost 30 years until the hospital closed our office unexpectedly during the pandemic. And I still teach at Geisel 3 to 5 days a week. And I just had a student ask me, did I think there was any hope for making any difference in making the system of medicine better this week? And I cited this committee as my example of why I put in time to do things, even though I sometimes feel like I'm banging my head into a wall.
Yep. Thank you.
Yeah, thank you. Skipping a couple names that I don't think I see. I had a second to look through the list. I don't think I see Courtney Ledger or John King, who told me he probably couldn't come tonight.
I see
But
Courtney.
if I'm wrong, they. Oh.
I think Courtney just popped on, Julia.
Oh, great. Well, Courtney, if you're in a place to say hello, we're just saying name and where you practice.
Hi, sorry I'm late.
No problem.
Working. I'm Courtney Ledger. I'm a nurse practitioner at Richmond Family Medicine.
Great. Thanks for hopping on. I know a lot of people come straight from work, so it's a long day and we appreciate everyone's time.
It was Dr. Rice on our list, Julia. If
I
he's
am
not
getting
willing
to him in
Oh, sorry.
two.
See,
Yeah,
I'm gonna put
I
myself
said
on mute.
alphabetical and then I realized my list was not as alphabetical as I thought. So apologies if I freaked anyone out. I think I have Amelia next, and then we'll go to Dr. Rice.
Hi, I'm Amelia Florence. I am a doctor with Gifford Primary Care and I'm their clinical coordinator as well. I've been up here for about 5 years.
Thank you.
And Dr. Rice.
Hi, Paul Rice. I'm family medicine in Williston, Vermont, Evergreen Family Health. We're 18 practitioners, 3 of which are primary care sports medicine, and also chief medical officer for Health First, which is the statewide independent practice association.
Right. Great, thank you. We'll want to talk to you separately about your other hat when we can, please.
Sure. Glad to.
Great. And then Kristen.
Hi, I'm here. I'm Kristen Sheehan. I'm primary care, I'm a nurse practitioner. I do primary care here in Rutland, Vermont. Been in the community providing primary care for about 5 years. I also work with a large population of our homeless people.
Oh.
I do that as well.
Okay. Thank you.
Great. That is my list. Were there any other PCAG members who joined after I called their name and didn't get a chance to introduce themselves? Okay. I think we covered it. Great. Thank you. Before I get into the second agenda item, I was going to hand it over to Susan for an announcement.
Yes, thank you, Julia, and hello, everyone. I wanted to share that Pat Jones, who's the interim director of healthcare reform for the Agency of Human Services, received your memo. She was very thankful for your memo. She wants to follow up with you on your memo, and she also wants to find a time to speak with all of you about the AHEAD model. As some of you know, two things. The Agency of Human Services is leading the efforts on a next potential model with the federal government. And so she particularly wants to talk to you about the primary care program that is proposed in the AHEAD model. So putting that out there to you, Julia, probably at the end, we'll talk about a next meeting, but we may want to come back in December and she can do it then, or we can find another time. I think the best thing to do would be to just maybe shoot Julia an email on your preferences, or we can do I don't want to get off track. We can just do a quick straw poll here. I know time is short on the AHEAD stuff, so the options are we wait until December, or we schedule a separate meeting that Pat can have with you on that program.
And maybe Susan, we could just send a note to people and
That's
I
a good
can make a
idea.
couple options of
Great.
times that Pat could come talk to you all and see, kind of like I did for this meeting of saying, tell me if you can't make this time. So maybe that would be easier so people can look at their schedules.
I think we might want to shoot for a second or an earlier meeting, though. December seems
Far. Yeah.
end of the line. Yeah.
Okay, great feedback. Thank you all. And we just needed the most of the time for this topic, and so we didn't think that we'd had enough time to cover everything. So I agree with you, Faye. We'll reach out and get something on the books.
Perfect. Thank you. Always hard to do group schedulings, but yeah, we'll take a look at some options and send them around. Okay, great. So the second item on the agenda that I wanted to just cover quick is to kind of do a tour of the website that I sent out in my email, and just orient folks because there's a lot of community meetings coming up. And it's a little bit out of order because the meeting that we're having tonight is similar to those community meetings. So Bruce is going to give a lot more sort of context on Act 167 and this work. And I know PCAG members have been hearing about it since the legislature passed it in 2022. All the community work to go out and talk about how we can improve our healthcare system, which you all will be giving lots of thoughts on tonight. But Hillary, if you're here and ready, I was going to have you help me screen share the website page. So as I said in my email, we have a bunch of community meetings coming up. And I just wanted to take a minute to show everyone, this is the page that we sent out. And all of these community meetings are going to be facilitated by Bruce and his team. And you'll get a taste of that this evening because the slides that we're going through, that Bruce and his team are going through tonight, are going to be essentially what the provider meetings are. So you're getting a sneak peek of what that will look like. And so our ask to you all is kind of twofold. First is to register for the meetings in your area. And second is to help us get the word out, both to providers and community members. So on the website here, it's organized by region. So as you kind of scroll down, there's like tons of meetings. They're organized by region, so you have to look at the dates under each section, which means you could share this website with people anywhere in the state and they can navigate to the meeting for their region. And at the very bottom, there's also 4 statewide meetings that we have. So if people can't attend the meeting that coincides with their region, they can also come to one of these statewide meetings. The provider specific meetings are being held at 6:30 to 8:30 p.m. because we got feedback that providers have work all day and couldn't come to a meeting in the middle of the day. So that's why those are scheduled that way. They're all virtual. They're on Zoom. You can register on the links on this page. And by registering, it'll send you an email with all the Zoom information, which you can add to your calendar, which is great. But yeah, so basically this is the website. At the very top, there's a little bit of information about the sort of like, how do you know which meeting to sign up for? Because not everyone, maybe you live in one region, but you work in a different region. So really there isn't a clear, like where you live is where you have to go to the meeting. We really want people to come to meetings for regions that they have a connection to. So I think especially for the provider groups, it probably makes sense to think about coming to the region where you work, but maybe you also, have a strong connection to some other community. So really it's wherever makes sense to you in terms of attendance. I will pause here. I think looks like Faye has your hand up. Didn't save me from my unstructured talking and ask your question or comment.
No, I just wondered if we could get a little clarity on if what we providing tonight is the community engagement, or are we just learning about the community engagement? And so if we do this tonight and say what we feel is important, do we need to go to those other meetings? Or is our attendance there vital?
Yeah, so that's a great question. So
short answer is we're hoping for your input tonight. You would not need to attend another meeting unless you wish to. Is that helpful? Sorry, Julia.
No, that was very succinct. Thank you. Yes. Yes, tonight is essentially the same as the provider meetings. I would say if people are interested, it might be of interest to attend the meeting for your region or a region you're interested in, just to sort of hear what other colleagues or just people in your area might be talking about. But for the sake of us collecting your input, like Bruce said, we're doing that tonight, and I will let Susan add.
One quick question. This is a question. Did these folks get that flyer that they could hang in their offices? Okay, so you all got a really great flyer that you could put up in your offices to help get the word out to your patients. And that's the other thing. I think Bruce and Julia, you're right. Like, you wouldn't have to go to another meeting. You can if you'd like, but really helping us get the word out would be super great.
Yeah, and I can resend that flyer in the follow-up from this meeting so everyone has it. But yes, so the provider meetings, you will get a taste of that tonight. And we would love for you to encourage colleagues of yours to attend meetings for whichever region makes sense. And then the community meetings, like Susan said, if you're able to hang a flyer in your office, or if you have, personal friends and family who you think might be interested in joining, you can share this with them. We're doing a lot of work to try and promote this in many different venues, like via organizations, via the news. But to the extent that people get personal advice, we think that goes a really long way for getting folks to join these meetings. So we appreciate any help you can offer with that. Yeah, so without further ado, I will happily pass it over to Dr. Hammery and his team to lead us through a provider meeting, provider feedback meeting. And in addition to you all going through the meeting tonight, I did just also want to say, as our primary care advisory committee, we also welcome afterwards feedback that you might have about how the meeting went, or how we can continue to get better at getting input from providers. So kind of wearing both your provider hat as a participant in this meeting, but afterwards also your advisory hat. We welcome that as well. So now I will actually pass it over to Bruce to take it away.
Great. Thank you very much, Julia. We appreciate it. And again, thank you to everybody on the call. We're really looking forward to your advice and counsel. This is a listening session. It will be punctuated with some questions. But it is essentially the same thing we will go through with each of the provider groups and provider broadly defined. This will include everybody in the list that you had sent that is included in primary care services as well as specialty services. We're anticipating being able to include pharmacists and dentists as well. For example, social service staff, emergency medicine technicians, and others involved in direct patient contact. And I'll get to that in a minute. Next slide, please, Sam. So this is a little background. I think you're aware of this. There was a Rural Health Services Task Force incorporated in 2019. And Green Mountain Care Board required hospitals to develop sustainability plans. You're aware of the bankruptcy of one of the hospitals. On into 2020, the sustainability plans requirement was extended to all the hospitals and resulted in a hospital sustainability report referenced here. What we're engaged in is a result of Act 167 of 2022, which provides for several things. One is development of an all-payer model. AHS, the Agency for Human Services, is leading that effort. The second is development of value-based payments for hospitals, ACOs, and others, led by Green Mountain Care Board. The third is a regulatory process for Green Mountain Care Board to set hospital budgets and growth. And the fourth, which is the one we're engaged in, is the community engagement process to drive hospital transformation. And we'll outline that in a bit more detail subsequently. I will comment that although we are aimed at hospital sustainability and transformation, this has to take into account the fact that hospitals do not exist alone, and in fact their survival depends on both the availability and effectiveness, efficiency, et cetera, of pre-hospital services, post-hospital services. And you know, I would comment for myself, I'm in the view that you know, the home and the outpatient areas where care gets given, hospitals are a last resort. Okay, so this basically shows the four parts of that act. I've gone through these. You see the subsequent APM agreement is the go forward for the all-payer model that you currently live under. And we're all the way to the right on community engagement. This is a joint effort led by Green Mountain Care Board, but actively involving a lot of the Agency for Health, for Human Services, rather. Next slide. Okay. So we are reviewing data and we are endeavoring not to repeat data collection. So we've reviewed a lot of reports, a lot of the Green Mountain Care data, hospital budgets, that sort of thing. And we are in the process of soliciting input, both local and statewide. We're working with a lot of different groups. I'll show you some examples of those in a minute. And another contractor to the state is providing more in-depth data analytics, which will really serve to assess the impact of recommendations or options that might be developed. Assess those impacts both on hospitals and the community health. Next slide. Sam? Sorry, thanks. So here we are. We're going to try to shorten this introduction a bit. The main part of this is to listen to you all and to gain from your experience and expertise. Next slide. We have a small but elegant team here. I'm one of the members. As was noted, I trained as a physician. I spent 20 years in academic medicine, practicing and teaching, was associate dean and then and professor at Penn State, and then director of the university hospitals and chief operating officer for the campus. Moved to Geisinger, was there almost 20 years, most of that as system chief medical officer. So had responsibility for group practice of about 750 physicians, about 150 primary care folk, an additional 750 advanced practice folks, 70 clinic sites, 3 hospitals, about $2 billion in budget. We did some of the fun stuff. We were in the original physician group practice demonstration project, set up patient-centered medical homes with 24 access within 24 hours in 2002, developed bundled payment models, and so forth. So a lot of interest and so forth in that. I have been a partner and the chief medical officer for Oliver Wyman for 10 years. And have participated in things like a project the Duke folk did a while back to integrate primary public health and primary care. Ms. Elizabeth Sutherland is a partner, was at Oliver Wyman for a number of years, and I've worked with her. Well, she is an expert in health equity and is leading that part of this project, which is a large part. She supported the Pennsylvania Governor's Commission in their approach to achieving health equity in Pennsylvania, did similar work with the city of San Francisco and some other groups, and currently is a partner in another firm. Sam Winter. Sam, I'll let you introduce yourself briefly. Okay. Sam is, please go ahead.
Sorry, couldn't get off mute. Hey, everybody, Sam Winter. Been with Oliver Wyman a number of years, over 10 years in management consulting for the U.S. healthcare industry. Done a lot with various large transformation programs, value-based care. And so, really excited to be working with you all on this set of work, because it's not just important to Vermont, it's actually important for large swaths of the country. So excited to be here working with you all on this.
And Dr. Chidera Choueki is a 4th member, not able to be with us tonight. Chidera has a PhD in neurosciences with an area of specialization in alcohol and chemical dependency and tobacco use. Next slide. This slide is shows a timeline of where we are. Shows this timeline of where we are. We have spent time in July, August, and September doing a lot of work on gathering data. We are currently in this phase, September, October, and a good part of November, to do the interviews and the listening sessions around the state with the hospitals, with the hospital boards, with a variety of diverse groups, business leaders, general community members, physicians, nurses, and so forth. We will then take that data and the results of the input from all these meetings and develop a set of recommendations. Now, we're aware that you've been studied to death, and you have reports on workforce, on IT, on primary care, on rural health, on mental health, and we could keep going. So I've reviewed those, we've reviewed those, and we'll keep those in mind. Hope to supplement with some more current information about people's current experiences, and then use that information, the data, and the advice and counsel we get from you and your experience to put together some options, and then submit those to our colleagues in the other consulting group for more detailed analyses to look at impacts on both hospital sustainability, quality, equity, community health benefits, and so forth. And then we will bring those back in person to the hospital leadership and boards, and then to the general community. And we anticipate those meetings to occur likely February and early March, so that we can then take the results of that feedback on these set of proposals or potential proposals and reformulate, and then put those in a report that would go to Green Mountain Care Board and ultimately to the legislature. So there will be a feedback loop here, and it will occur really in two phases. And I want to be clear about this. The phase that affects the hospital directly, and remember, these are all potentials, they're suggestions, and they have to go through a set of approval and review processes, and they have to be agreed to by the hospital board. So the things that deal specifically with the hospital, we're going to talk about with the hospital. At the general community levels, we will talk about statewide approaches. And the reason for that's very clear. I have run organizations in small towns. I live in a small town. And there's no point in getting people upset about stuff that may never happen. Right? So we're trying to be very judicious in this so that we don't create unintended consequences, because this needs to be a thoughtful process, an open process, but a thoughtful process. Are there any questions or comments about that? Okay, so we're on a data gathering path now. It's virtual. We'll be back in person. So I look forward to seeing a number of you in person in a few months. Next slide. This is background. Basically, the national and state trends in healthcare are not going in a good direction, as everybody's aware. Costs are going up. There are shortages of every sort of professional in the medical field and health-related field that you can imagine. That includes pharmacists and lab techs and emergency medicine technicians, as well as doctors and nurses and others. Hospitals across the country have unsustainable margins, and families are unable to afford care. And we'll get back to that point in a minute. So in Vermont, there are a number of threats to the sustainability of the current system. One is there is a large proportion of the population which, although insured, is underinsured and cannot afford the co-pays, deductibles, out-of-pocket costs to receive health care or obtain medication. Hospital operating margins are declining. Days cash on hand are going south. And a project that I was part of or did about 1.5 years ago showed patient access and service wait times are lousy, and that you live with that every day. On the other hand, there are some new federal payment models that are being considered by Vermont. One of those is global hospital budget. Another is a different primary care payment model. And than in other areas of the country available in Vermont. Certainly the rural emergency hospital designation. One of the things that we are doing with some of the hospitals is exploring whether they've thought about that. And if so, is it a viable path for them? You're aware nationally that the feds are moving fee-for-service Medicare beneficiaries into Medicare Advantage programs. In other states, which are not rate controlled, they are in the process of reducing hospital ambulatory outpatient fees to the rates in freestanding units. So that's a movement that's beginning. Obviously, AHA and other groups are pushing back against that. There is a model which the state of Vermont is considering. It's one of the other work streams in Act 167, which is the AHEAD model. We have folks on this call much more knowledgeable about that than I do. I'm looking at Susan, for example. But this includes a global hospital budget. Hospital would get 12 equal monthly payments on some basis, be able to use those for inpatient and outpatient care and other services. But there would be accountability for a population for their total cost of care. And the details are being worked out. I'm not privy to that. It does offer the opportunity to transform hospital operations and healthcare delivery, but it's going to require a lot of preparation. And I think one of the other issues that we're beginning to discern is where hospitals are in that process and how much they've thought about it. Primary care directed payments are part of this total effort. So that was one of the points you all have raised to AHS and others. Next slide. Okay, so this says what you know. Every dollar that funds healthcare comes out of a working person's wallet, whether it comes through a payroll tax for Medicare, a state or federal tax that supports Medicaid or Bureau of Prisons or Federal Employees Benefit Trust or state workers' health insurance, whether they buy insurance or they have out-of-pocket costs, all of those things. So the pot of money is fixed. Okay, that's the bottom line. And we'll be making this point to the communities as well. Now, as I mentioned, Vermont has done a good job at allowing people to have access to health insurance. So only about 3.1% of the citizens of Vermont have no health insurance, as opposed to almost 9% nationally. But of those, that 3.1%, most say can't afford it. And very importantly, of the people in Vermont who have insurance, 40% are considered underinsured. That is, they can't afford the copays and the deductibles and the other costs associated with seeing physicians and healthcare people. And that's a big problem. Next slide. So this shows part of the issue, right? The median family income in Vermont, $67,000, almost $68,000. When you take taxes out of that, people are netting about $43,000. Now, of that $43,000, you've got to buy health insurance. And if you're buying a commercial premium, this shows total, so it includes the employer's cost. But you also then have to pay the out-of-pocket. And if you look to the right, if you have a platinum plan, you're paying a lot of money for it. You still have almost a $5,000 out-of-pocket deductible. So figure $5,000 out of 43,000 is not a good thing. Next slide. These are the wait times from the project 18 months ago. Certainly haven't improved. Pretty much a lot between the hospitals, but some of this associated with complexity, number of specialties, specialists, and so forth. Next slide. Okay. So that's it for me. And the question is, these are just a set of sort of thought questions to work through. Issues about being able to provide more access. And I'm going to stop and just welcome comments about access, about equity, about affordability of care. Are there things that can be done to improve those things? Have you read your report, by the way? I don't know, Julia, do you want to use your list and ask for input, or shall we wait for volunteers? This does not seem like a
I think we usually get some volunteers.
We have one, sir. Yes, sir.
Before we jump into details, I always like in group like this when certain terms gets thrown out. It'd be nice to define them. And one is health equity. If you just briefly could define what your sense of health equity is, and then the other term was value-based care. And that gets thrown a lot, sounds great, but it means a lot of different things to different people. Thanks.
I appreciate that. Thank you. Health equity means that everybody has an opportunity and can achieve a state of health, no matter what their background is, personal identification, language, religion, etc. Particularly interested, and I apologize, didn't show you a slide about all the groups, but it includes the unhoused. It includes people of different gender identities, different language groups, different ethnicities, different physical and mental health needs, substance abuse, and so forth. So broadly inclusive in terms of people having access to and the ability to attain a healthful state. Does that help? Probably a little bit narrower definition than Elizabeth would give you, but useful for working. Value-based payment basically means not fee for service, right? So it's not based on widgets. And you can, it can be a bundled payment. It can be a capitated payment. It can be a global payment. It can have when I was on the board of Mass Blue, we did a supplemental payment for quality and efficiency, which in some sense is value-based as well. I don't know if that helps.
Yeah, no, it helps to hear your definition of it, but the ultimate high value payment is a low cost fee for service service. So you pay fee for service at a low rate and it's high quality. That's the best value you can get. So I think it's
okay.
Right?
I hear you. With respect,
So
I don't think a lot of people would agree with that.
okay. Quality over value, quality over cost is the definition of value. So
correct.
Right. So if you get something of very high value for very low cost, then that's the highest value.
I understand. I agree with you, but I just think that anyway, I hear you.
No. I don't want to get into that. Don't want to sidetrack, but because not everybody defines value-based care as non-fee for service. It's sort of assumed. It's not, sort of assumed, but that's why I wanted to get that sense because we're all pretty much still in a fee for service environment.
Yes.
Currently.
No, I understand that, and I think the part of our charge is to look 10 years out. Right, and this is a very moving target, as you're aware. So, no, very aware of the fee-for-service aspects currently, but it does seem to be, and of course, it's been going on for, I mean, I was dealing with some of this in the 90s. Okay, so this movement is pretty slow, but it does seem to be accelerating more recently. But having said that, and definition of value, how do you think about measuring value? I mean, one of the things we've heard as we've talked to a number of the hospitals and the chief medical officers and folks there is that they're struggling with different definitions and different quality metrics coming from different agencies and different payers and different groups. So how do you all think about that, and can something be done to standardize or define that better? Dr. Penny.
Yes, I guess I just need a little clarification on what it is you're doing. I got the impression early on you're dealing more with the hospital sustainability plans. These questions seem more directed at kind of day-to-day what we're doing.
They
so I'm
are.
sorry, and maybe I didn't
No,
understand quite the initial introduction, but I guess I'm
right.
just not quite clear on what your objectives are.
All right. Well, let me try to be clear. I apologize. I mentioned that hospitals do not exist in isolation. And they suffer, some of them, from a 30, what a prior consultant said was a 30% rate of emergency room visits that could be prevented by good primary care. And in some instances, as high as a 20 or 25% rate of admissions that could be prevented by better or more access to primary care. They also suffer from some of them from a 10% readmission rate, because in part people either have mental health problems they can't have addressed, or they can't get in to see a primary care doctor or another physician within 7 to 10 days after discharge. So they don't get follow-up for the problem and it gets worse. I mean, this is national data too, right? So that is the reason that we are really looking at the way the ambulatory system upstream of the hospital and the discharge options and the options for taking care of people without a home or without water in the home, or with disabilities that require aids to daily living, and those sorts of things, how available they are, where they are, what the plan for them is. Because what we find in the hospital is that we have patients stacking up that don't need hospital care, that could be in assisted living, could be in a nursing home, if they had a good home environment. So that's the reason that we're honing in on some of this, right? Because if you simply look at the hospital and say, well, gee, guys, if you just got them out of the hospital a little quicker, you wouldn't have the problem, right? So that's the reason that this ties together. It's we all understand the physiology of this, right? It's not a unitary problem. It does not exist in isolation. And so while we're also interested in how this system interacts so that the hospital can be more sustainable, and if necessary, not necessarily as a bricks and mortar institution, right? I've reviewed the mission statements for every hospital in Vermont, and they're like the one of the little hospital I'm on the board of in Bozeman, Montana. Doesn't say anything about keeping the building. It says community health. Does that help, sir?
Yes, yeah, thank you. It's good to hear that you are taking a global look at pretty much everything, it sounds like.
Yeah. Well, I'm an ID guy, so we try to do diagnosis before treatment, if that makes sense. Ms. Wolfman, do you have, or Dr. Wolfman, do you have some comments?
I have many.
Good.
First of all, I did my residency at Geisinger, so I noticed
When were you there?
I was there from 91 to 94 at Napper Clinic.
Oh boy.
And
well, you had a good group, so you knew Dr. Toretti in that group, and you were there a little before I was.
I had a great training there. I'm glad I went there. Yes, it's hard to know where to start. I have a lot of thoughts. One of the main things on my mind, and I was in a meeting earlier today about the AHEAD model, and something that came up that I think is important is, having worked in hospitals and primary care my whole career, I think there's a disconnect between what hospitals want and what primary care clinicians want out of their job, basically, out of their work, out of their life's work. So when I was at the CMO at Porter Hospital, the CEO came into the room one day and said, "Great, the ER is full and the main floor is full." And I said, "You hired me to help with population health. I don't like what you're saying. That's in conflict." So I think until we can shift that mentality, we're going to keep having this battle.
Yep.
So that's one thought I have. Another thought that I think is important to look at is, according to what I can find on the AAMC, there are quite a few physicians per capita in Vermont. I think we're in the top 3. We used to be in when the numbers were last run. But I think that people live here for a way of life, for one thing. They don't want to be, going through widgets all day, 5 days a week. And I think that's good. And I do think there could be some creative ways that we could increase availability. So we use the word access all the time, but true access is being available when the patient needs and also wants us. And I think we might have some room to work on that. Yep. I have a lot of other thoughts, but I don't want to hog the floor.
No. May I just follow up, because you've hit on a point I wanted to explore. You're exactly correct about AAMC data. When you look at the State Board of Medicine data and the number of clinical FTE, that number is roughly half, somewhere between half and 60% of the number of bodies, doctors, if you will. And, as somebody who's practiced for a long time in big hospitals, my guess is, and the other unique thing about Vermont is that roughly 65% of your total physician group is employed at the university, right? It's a huge employer. And so it sort of skews that data. And the other thing I wonder, is when I think about the clinical time I spent, now ID may be a little different than other things. A good part of it, pre-AIDS certainly, was in the hospital. So my clinical time would not have been available to a patient who wanted a clinic appointment. And I wonder how those factor in. I mean, certainly lifestyle, we see that in Bozeman too, right? And I'm sure that's a factor. But so I'd be interested in your thoughts or those of others about that sort of thing. Other thing that strikes me is, if you look at AAMC data and the AMA master file, Vermont has roughly half the proportion of foreign-born and foreign-trained physicians that we do nationally. And that also seems to be the case in terms of the trainees at the university. So, I mean, not aiming at the university, but just saying at a state level, that's an issue. So comments, thoughts, I mean, it would seem there are some opportunities in some of that.
I personally agree with you. I think the second statement you made is that's something I didn't know, or, it's kind of obvious when you stop and think about it, with the lack of sort of an equitable workforce, a diverse workforce. With your first comment, I know what the work schedules are for primary care FTEs at UVM. And I think one area that is helping, and one thing I personally have tried to do, is add telehealth hours in the evening. That's an example. I feel like for primary care, we need to be more creative. Patients are going to urgent care in the evening. When you showed those financial numbers earlier, and I think about my patients, they don't want to miss work. They need their job. So they need to go to the doctor's office or the primary care office when they're not at work. That's just one point. I think there are ways we could be more creative with availability.
Thank you. Other comments on that, Dr. Rice?
I think Faye had her hand up before I did. I'll defer to Faye.
Okay, sorry.
Thanks, Paul. If what you had to say has to do with directly what was just discussed, please go ahead, because I was actually heading off on a different tangent.
You go ahead, Faye. I was also.
Okay, good. So, when thinking about the things like the wait times for specialists and better access to care, and you said, you talked about the difficulty with primary care, that we could keep people out of the hospital better if there was enough primary care, and we could decrease readmissions. I mean, I think that's gospel to all of us. I think we all know that, and there's just too few of us by a mile. We have months and months wait lists to get people into our practices. So there's not enough of us. Let's start with that assumption. We have to figure out how to train more people, how to get them into primary care. Sure. We probably need loan repayment. We may need to somehow, and I don't know how to do this, but I hope people who study health policy do, somehow raise the salaries enough that people are intrigued with primary care. We see all the time students who come work with us and love their experience, and then have $400,000 of debt and can't make this choice.
Right.
But I wanted to just talk about what happens in my normal day, in my everyday, that slows me down and makes me unable to see more patients. Good. I see far fewer patients now than I did at the beginning of my career, because of a number of things. And a couple examples are, we get data dumps of information from specialists and from hospitals when we send our folks off. So I had a 30-page ED note that I reviewed this morning, and all I wanted to do was find out if the patient was admitted or sent home, and it was 30 pages long. So let's talk totally practical here. On page 1 of your hospital discharge summary and on page 1 of your consultant note, there has to be an assessment and a plan. Don't make me dig through the last 10 years of all of the chemo they've been on. Right. Page 1, an assessment and plan from every specialist and from every hospitalization. Mm-hmm. That would be one thing that would help just free up our time so that we could see more patients. Another thing would be phone availability of specialists before the consultation takes place and afterwards. It would save so much time. Patients will get in sooner, and many probably wouldn't need to see the specialist at all. If I could pick up the phone and say, look, I think this is a rheumatologic condition. I've tried X, Y, and Z. I've done these labs. Are there any other labs I'm missing? Is there a med I can try in the meantime before they get in to see you? And we don't have that availability, and it would keep the system going. The problem really is that we are beholden to different. Well, never mind. So someone would need to help the specialists change their behavior, and I'm not sure, and our behavior as well. So I own that too. That primary care providers need to have a broad comfort in treating lots of things, keep the scope broad, and we need to own that as well. But I think a specialist should have to tick a box at the end of every note that they write that says this patient needs ongoing specialty care, yes or no. And if it's yes, fine, do the follow-up. But if it's no, don't have that patient come back in 6 months for their stable atrial
Okay.
fibrillation or for their routine full skin exam in a low-risk patient. There's so much work that our specialists are
Right.
doing that's primary care level work. So that was my tangent. Those are some practical
Good.
ways I can see more patients.
But
Hey,
it's
Dr.
not a
Yeah.
tangent. Thank you.
No,
I
that's
guess,
not a tangent at all. Yeah. Dr. Hemery, if you don't mind, Dr. Homan, we
please.
actually heard very similar thoughts from other primary care physicians we were actually speaking to just earlier today from Porter Hospital. Now, they've said like almost word for word some of the similar pain points. These data dumps that you're getting, are those through one-off interaction faxes with specialists, or is this through the HIE? Or do you not know?
That's everything that comes into my inbox in my electronic health record.
Okay.
Okay. So that's not formatted in a way that's at all helpful, it sounds. You got to get to the bottom of the 30 pages to find out what really is the plan.
Yeah, that's correct. And when we have worked with our local hospital, one of the things in the ED notes from my local hospital is that every lab and every x-ray is in there 2 and sometimes 3 times, which just kind of makes it this giant note. And when we have worked with our specialty, our tertiary care center as well, saying, what can we do about these? We are, there's just kind of, there doesn't seem to be any way to get the hospitals to change what comes to our offices. That would be an amazing thing for healthcare reform if that could happen.
Yeah. So I guess a question about that. I used to spend a lot of time figuring out ways, to a prior point, trying to figure out ways to make sure that patients would be able to come to Geisinger, come to Penn State, and get back to the referring doc. And part of that was the communication you're talking about, right? Surgeon calls the referring doc from the OR. Here's what happened. Nothing worse in a small town than the doc walking into the grocery store and finding out their patient died or had a complication. So I guess what's different about the referral hospitals that you deal with that would not encourage them to make your life easier so that it's easier for you to get patients to them?
I can answer that. I think somewhat simply. We have one hospital in each community. There's absolutely no competition. I've said this when I've tried to do what Faye's talking about, is change at least what the consultants send us and what the ER notes contain. Many of them can start with abdominal pain, and at the very end, when you look for the diagnosis, it ends with abdominal pain. There's no discussion, there's no plan, there's nothing after you go through those 14, 15 pages, and you've wasted your time.
Yeah.
And I've talked with them at length about it, and one of the things I've said to them is, if there was another hospital in town, you guys would be out of business. This is not, the way you treat your primary care docs and your referring docs is just, it's just not sustainable in a regular business model. And
Right.
so because we're stuck with it, we don't really have any control over that, despite many of us having tried. Now, I'm just talking, I don't know what it's like in the smaller the community hospitals, but certainly our big referral hospital, we don't have much say over the kinds of notes and information we get back.
Okay, helpful. Thank you. Thank you. Other comments, please, Kristen or Dr. Rice?
Yeah, so I was going to go exactly what Faye was saying. We're overwhelmed with so the ability to do coordinated comprehensive care is very, very resource intensive and very costly. So we can't take care of nearly as many patients as we used to. I have the largest patient population in our very large group, and it's 1,300 patients. And somebody from another state told me the other day that, wow, you have a very small patient population. And it's like, no, this is It's overwhelming. Many of my practitioners who are full-time, can barely handle 1,000. It's because of the number of calls and documents. Anytime a patient touches the system anywhere, we get a document that we have to review and sign off and put in the record. So it's that overwhelming, as Faye said, data dump. That's one thing. Go ahead.
No, please finish, and then I want to ask you a question. I apologize.
Well, there's a couple other things that I'm trying to sort of answer this. What issues limit our ability to provide care to more people? Our current practice, we've lost 5 practitioners in the last year and a half for various different reasons. We have 2,100 patients in our practice with no primary, and all of our primaries have been full. So we have nowhere to put them, and it's burning out the current patients that we do have. When I retire at the end of next year and my other partner of the same age retires at the end of next year, there'll be another 2,000 patients without a primary. And the problem is that we can't attract more practitioners into this type of setting because it's not attractive. We can't offer the kinds of levels of salary and workplace balance that the people want to practice in. And we certainly can't compete with other states that that don't abuse primary care as much. There's lots of other people places where there's not as much reporting and prior auth and complexity and medical home and small amounts of money from this, that, and the other thing. And so we've been trying and we just can't attract folks. So that gets in the way. In terms of patients, the underinsured is a big problem. To have copays and deductibles for primary care seems to make absolutely no sense to me. So patients want their care by phone and by portal for free. And you can't blame them. They've paid a lot of money for their health insurance. They're underinsured and have copays and deductibles. They don't want to come in. So they want us to provide that care without a visit for which we can't get paid. And then very high overhead. We looked at this today. We have 4 employees for each practitioner. So each practitioner needs 4 employees to support that one practitioner who can see 1,000 patients. That's just outrageous. And one of the inputs that I would suggest that maybe you get is that we've got a lot of very, very good primary care physicians who have opted out of the system, and who can blame them too. And they're doing direct pay models, whether they're hybrid or fee only, concierge or direct pay or retainer medicine. And they are the happiest primary care doctors in this state. And I've talked to several of them, and they are very, very happy with primary care. And so there's got to be a middle ground, but we should bring some of them in, or at least have 1 or 2 of them on this committee, because they're providing healthcare in this state.
Right. Well, and if you would, I would appreciate it. We have email addresses in the last slide of this, and if you wouldn't mind, or others on the call wouldn't mind putting me in contact with some of those folks, I will promise to get a group of them together and have a conversation. That would be very useful. Thank you for that. And the other question, I apologize for interrupting, but the other question I have is around the paperwork and the pre-auth and all that. We've heard from a similar thing from the hospitals, in fact, that there are multiple programs. Each one of them requires different paperwork and different quality metrics, and they have also a lot of administrative cost in that. And I would really appreciate some additional color and some additional information on that, please.
Did you want that now? I wasn't sure.
Yeah. Oh, well, or you can send it to me, but a little now, a couple of minutes would be very helpful, I think. And then I'm sure others will will
Right.
chime
Well,
in to help.
there's for a number of things for prescribing medications, and it's not uncommon for me to prescribe a medication. Later in that day, I get a call from the pharmacy or the patient. It's not on my formulary. Give me another one. And like, oh, we haven't talked about another one. And I don't know what other ones are on your formulary, or your particular formulary looked like you had Blue Cross, but you really don't. You have a Blue Cross Advantage plan, or you're self-insured and it's just looking like a Blue Cross network, but it's
Okay.
not really. And so it's impossible for us to juggle these formularies and manage these medications. Some of which are generic medications that have been around forever, and now they want a different generic or that kind of
And
thing.
there's
And then
there's not a substitution that the pharmacist can make if it's an equivalent.
many of them, they require you to write a new prescription, or it's subtly different, or et cetera, et cetera. So no, even if you write it generically, you often, sort of have to write it differently, or they want a different generic drug in the same, class of medications, for example.
Okay. Thank you.
The other is the prior authorization for tests and procedures. There's that you have to go through differently for different insurers. But to back up on the pharmacy one, the big problem here. It's not really the insurer, because the insurer outsources that, or if it's a self-insured, they have a pharmacy benefit manager that does that. So the real farce here is that the pharmacy benefit managers put us to work for free. We don't even work for them. We work for the health insurer. We have no contracts with the pharmacy benefit managers, but yet they make us go through hoops and do a lot of work without paying us to manage their formularies.
Yeah, sure. Sorry, Dr. Florence.
I think there may have been somebody before me. I apologize. The
Okay.
name's
I'm sorry,
hidden.
Kristen?
Kristen. Yeah.
Kristen, I apologize. I wasn't looking at the whole screen.
Oh, that's okay. No worries. I think I'm just going to start by saying in the Rutland community is probably about 20 years behind. I know you were talking about the data dump that you get in your inbox through the EMR. Rutland Hospital is still faxing me 32-page documents via fax on patients. There is nothing electronic coming to our offices out of Rutland Hospital. We have to log into their network to look up any of the stuff if we don't want them to fax us all this paperwork and weed through it. It's just a really antiquated process. And then to do a referral to Rutland Hospital, each department has a separate referral form that needs to be filled out. And then you have to send that with the patient demographics, your last note, and the firstborn of your patient so they can get them on this wait list. And then they're waiting 2 to 3 months to get in, and then they get their procedure canceled or whatever, and it's rescheduled for another 6 months down the road. One of the problems I've had here in the community is specialists like our gastroenterology decided not to take new patients. So I had nowhere to go with these patients. Some of my homeless people, they don't have transportation. They don't have the executive functioning to figure out how to get to Dartmouth, to UVM, So it's really frustrating working with that population, And then another time I had with, someone that was scheduled for two preventative colonoscopies. Someone had Medicare, they scheduled them like 6 months out. One of my patients with Blue Cross Blue Shield got scheduled 6 weeks out. So it's a prioritizing of medication, and that affects equity, like the healthcare equity. I mean, I get Blue Cross Blue Shield pays more than Medicare. I understand that. And I get where the hospital's coming from, but it doesn't help those patients, The other thing I've got a whole bunch of stuff from notes here. I'm sorry.
No, it's fine.
I think another thing that affects us in Rutland is, there's not a lot of case managers to work with these people, and that affects, I don't work for the hospital, I work in independent practice, so it's tough because we're very small, and we get some really sick people that come to our office, and I don't have the resources to get them set up with all the social needs that they require, and it's banging your head against the wall. And then there's just a lot of my patients, specifically the homeless, they don't seek out care because of the stigma that they face when they go to the emergency room or they go into one of the community health centers. It's just, they just don't go.
So is there I'd like to explore that just a little more, if I may, because, one of the things that keeps popping up is the ability to coordinate care, get some of these services done. We've not yet had a chance to talk to the state people that are responsible for that coordination. So, I'm interested in your comments about that, and then learning a little more about whether there are ways to make that service more acceptable to the patients and the people that need the service, and more available to you and your staff so that it can be more helpful. Are there thoughts about that, or things that have been tried and didn't work for some reason?
Yeah, actually, there's Vermont Chronic Care Initiative, VCCI, which is a place for the state for these high needs. And I can tell you the two case managers that I work with at VCCI caused me so much more work than if they weren't involved. I have patients that were doing very well, and we refer them to VCCI, and next thing you know, I have so much more work to do dealing with the case managers because they want, this done and that done. And one situation, I had a patient who was being managed here in primary care for anemia, and suddenly I had to do a referral out to hematology for iron deficiency anemia, and there was no reason for it. Just little things like that. I think it's frustrating for me. I'm tempted not to refer people to Vermont VCCI or other places because they don't seem to have that understanding of how much effort it takes to do a referral or to do, get someone scheduled for stuff, and if it's not necessary and it's not needed, we shouldn't be doing it. We shouldn't just be putting people into specialists just for hypertension. It shouldn't happen. It's waste of money.
Yeah, well, and so it sounds like there's also a lack of understanding of what I'll call medical necessity.
Yes, absolutely. Absolutely.
Okay. And do they talk to you about that?
Sometimes they do. A lot of times they don't. I actually get more out of the notes from the stuff, the conversations they have with case managers at the hospital. I read the case management notes to find out what VCCI is telling the hospital. I don't ever talk to them. They may call and talk to one of the girls in the office, but I don't get that feedback.
Okay.
So
Thank you. Very, very helpful. Dr. Florence.
Thank you. So echoing, I think, a lot of what people said, I appreciate what Faye and Paul definitely agree with a lot of that. The specialist component, honestly, it's so hit or miss up here. It's very fascinating. I came from Virginia in a much more populated area. It is unclear. Are you going to follow these people forever? Don't tell my patient, come to me anytime you want. You actually don't mean that. Please be honest to me. Just help me out. And what Kristen mentioned, I think I tried referring to that GI doctor you mentioned, and my nurses spent hours trying to explain this to the patient, why I could not get her into Rutland. Like, they didn't even have the, I guess, respect to call the patient and say, like, I'm sorry, we do not have a liver specialist right now. All she kept saying was, I've been there, why won't they see me? And we're like, they won't, but we're sorry. It was just ridiculous waste of my nurse's time. We're streamlining the EHR. I think part of this, as the bigger systems keep happening, and we just switched into a new EHR ourselves here at Gifford, the HIM department, I think, does a lot more than what us providers think. I think in the rulemaking, because I've talked with the ED coordinator at Central Vermont, and he's like, "Are you getting this information?" I'm like, "I get it 6 times, and all I get is that you've changed the meds, but not your actual report of what you did in the ER. It's not helpful to get that section."
Right.
And he's like,
Yeah.
"I swear I told them to send you guys this." Nope. And we're being managed more and more by people who are not clinical. We're being managed
Yeah.
more and more by people who have stepped away, who have healthcare training. I get staffing is tough. An MA is not a nurse. So that what I think Paul mentioned about the pharmacy, I'm with you. I get the pharmacist tell my patient, "Well, I don't have," everyone knows the weight loss, Wegovy, just do Ozempic. Your Ozempic won't be approved because you're not diabetic. Well, they said it would work. I know it won't work. But now
Right.
I have to do extra work because somebody who actually does not understand exactly what else we need to do. I'm not, I mean, because it's not the pharmacist. I think they are also hiring lesser trained techs to do these jobs because that's all we can get.
They can get, yeah.
Yeah, I mean, I've seen it with respiratory. They'll make suggestions for a new inhaler. I'm like, "You do know you're giving my patient 2 LABAs right now." And they're like, "Oh, I didn't know that." I'm like, "That's why you don't recommend meds. Thank you."
Yeah.
The VCCI that Kristen mentioned, we had a really great one up here, and she switched jobs, and it was, you could tell immediately. I agree with returning the work to primary care. We do have a community health team, but I get almost the same thing. I think what Faye mentioned, primary care, we know what needs to be done for these inequity areas. I don't think we need more committees telling us what areas are missing. We need the next step of, how are you going to fund the transportation? How are you going to help fund the food? How are you going to help fund the difference of these insulins? Sorry in advance. I hate WellCare. My patients who can't get except the one insulin that they want to cover, and they still have a crazy copay. We all know this. We need that next step. And I think sometimes VCCI and some of these community health supports, they're great at identifying it and just dump it right back. And I'm just not seeing that. I also echo too, Paul, with the DPC. I've had some friends out of state that are recently switching to this, and they're loving it. It's a great thing. I went to med school. I actually did a special program that included working with underserved populations. And all I think is, while maybe my life would be better, all I'm thinking of my patients that there is no way they could afford that extra out cost monthly. So that's just going to dump them more onto my colleagues at the FQHC I just left, and it's tough because you're just like, well, do I keep working until you can't do it anymore? And then they don't get me either way. How do you manage this? But
Right.
yeah, honestly, I know it's kind of the last question in your list. In a perfect world, if we're going to get data dumps, if we're going to do this, if we're going to streamline and use an AEHR, should we all be on the same one? And the state supports smaller communities saying, "You know what, you're this size, we will help fund this, so all of you are on the same system." Imagine the work we would not have to worry about. "Oh, you got this in the fax bucket. I don't need it. We all use the same EHR." Would love it. For me, that's just the base. But thank you again. I echo pretty much what everything said. Appreciate Paul, Faye, and Kristen so far. And I think Eileen's right after me, so I'm sure I'll probably agree with what she says too.
No, thank you. Very, very cogent comments. It is interesting when I look at it, when the team looks at it, that you currently have 5, I think going to 6 hospitals in the state that either by virtue of being affiliated with UVM or Dartmouth are going to be on Epic. And Geisinger, as you may know, was the second Epic install in the US, done in '97. And it's a system that's evolved. It does, as I understand it now, and I've not been in this for a number of years, but it does have the capability to talk to some other systems. Is the effort toward a state health information exchange going to help any of that, or make it worse, or just be different?
I'll quickly jump just since maybe it's still my turn. So I was our main person in Meditech as our rollout. That's what we switched to, their new one, because we are a weird setup here. But
Yes.
When I've been in other EHR discussions down in residency and things like that, you start getting into a little bit of a proprietary war. Epic
Yeah.
doesn't want to
Yeah.
talk to Cerner. Cerner doesn't want to talk to Epic. 100%. And the things that they need to communicate to share is what they consider proprietary sometimes, I feel. And so they're putting up a wall. In the end, it's about business. They want to make the money, and they're not going to, I think, unless, unfortunately, I think I said this in our email when we were talking about the memo a while back. Unless somebody important or with a lot of power gets unfortunately hurt by an easy mistake that could have been clearly stopped by med list errors or something like that, we're still allowing it to happen. I think in my example there, I had a patient that went to the ER. At no point did they talk to her that she's on bubble packs. They sent her home doubling a med she wasn't even on. And then she went back and got antibiotics, which they didn't realize she can't drive. So she waited 2 to 3 days until that antibiotic was delivered to her. And in between all of those, we called the ER to say, please update your list. This is her correct med list. This is what is going on. And they just were kind of like, okay, next time we'll make sure. And it was they have meds from 5 years ago that she hasn't been taking.
Yeah.
So
okay. No, understand.
There is,
I guess the latest out of the Office of National Coordinator was they had some agreement between Epic and Cerner and a few of those, but we'll see.
They have like little links in between that sometimes we'll share, but the flow has always been very, I don't know, everything that because I came from an Epic area, and they had set it up where if you signed in, you actually gave permission to the local ERs to share in between each other. And it was probably the nicest I'd ever seen, but they both were on Epic.
Yeah. Yeah. Well, you can do that through an HIE if it's set up right, and you can get meds and you can get lab and you can get diagnoses usually. But at any rate, sorry. So Dr. Murphy.
I'm not sure if I was
Wait a
next.
minute. Yeah, just a second here. I've got to go to the little gizmo. Dr. Tanner. Yep, my apologies. Thank you.
Yeah, hi. I'm going to go back to your comment, or your request for PA examples.
Yes.
I asked one of the health centers in our health center in Island Pond, just to keep track for a week, how much time they spend or how long PAs take. This is back in July. And time ranged from one or 2 or 10 minutes. They're usually that was rare. Most of them are 20 or 30 minutes. Some were days. Mostly meds, some referrals. They also asked the triage nurse in our office who does PAs to keep track over 2 weeks. The total time added up to close to 30 hours of nursing time to do prior auths. So I just wanted to comment about that.
Thank you.
Our FQHC runs 5 health centers and 2 urgent care centers. We're trying to stand up, expanding our community health workers into the urgent care centers. So when folks come in with housing issues, food issues, there's somebody there that can hopefully guide them. The problem is we're nibbling around the edges. Housing is short everywhere. It's impossible in the Northeast Kingdom. And so, yeah, you got somebody that's going to help you, but there's no place to go.
Right. Right. Thank you. We had that conversation too.
The other health equity thing we're starting to think about is streamlining the transition from the Department of Corrections and people coming out of prison that are on, particularly for MAT, or medically assisted therapy for opiate dependence, and have that transition go a little smoother. Anecdotally, we are going into a new EMR in a month. We looked at Epic, cannot afford it. It is just crazy expensive. The HIE is a nice concept in real time. It's just not practical. If you really, if you've got somebody in the room and you want to do a med, it takes a lot of time with the current system. Okay. And this is not going to happen in my professional lifetime, but my hope is that AI will solve a lot of our problems will consume every incoming document, look through it and point out the deltas. What's different? What's changed? New med list, new med, those change. So that would be a godsend. And another application for AI is to take natural speak and turn it into the diagnostic codes and billing codes so that I can just do my assessment and plan and all the billing and coding is done without having to do more clicks.
Yep.
Hey, Dr. Tanner, follow up on the exchange comment you made. You said it's much too slow. Is it much too slow because the data that's coming in is latent and aged, or is it much too slow because of the structure and you're getting 30 pages and you have to sort through it?
It's sort of, you want a med list and it's start at A and it's every amoxicillin ever, and to try to find
the structure.
Yeah.
Okay. Thank you.
Yeah, Dr. Tanner, would you mind if Ms. Sutherland and a couple of us reached out to you for a little more conversation around the transition from prison to community?
No, I would not mind.
That would be wonderful. Thank you, because that's also an area of interest for us in terms of equity and so forth. Okay, let's see. Ms. Murphy, or Dr. Murphy, rather.
Nurse practitioner, but thank you.
Oh.
So first, just for the PCAG folks, the AHS memo, I'm really glad that that's being paid attention to and people are noting points in that. As follow-up to a previous meeting, the Oliver Wyman group also got our primary PCAG priorities and also the presentations that we gave to Green Mountain Care Board that listed a bunch of things we talked about tonight. So they have it in writing. So your previous work has not gone unnoticed, which is great for us in PCAG to actually have some idea people are reading it and paying attention. So just so everybody else on PCAG knows that. My comment to follow up on the others is that this is still coming down to money and where's the money going? And there's obviously money to be made in primary care because otherwise the large corporations would not be going into it. But then they're also cherry picking the patients that they can either get insurance money from or they have private funds, the direct care, et cetera, and so on.
Right.
So when we're looking at and I will use percentages that'll be estimates, but people will get the picture, they're just not accurate. How many patients are we taking care of? The chronic illness and all of that, it's the 80-20. So we're spending time on those and those need more time. Because of that lack of funding coming down, that pushes down on, well, we need more efficiency, so we use IT. And we all know that electronic health records are just not useful, not helpful. There isn't one out there that's actually that good. We have some that maybe are better than others. And I started in the computer industry before I went into healthcare. So that's coming from somebody who actually helped with some of that way back in the day. It's pushing it out to IT folks who don't know. And then the push on finances is also pushing down on who is taking care of the patients. So when people were talking earlier about their large in baskets and doing phone calls at night and taking care of the patient portal, a lot of that is getting pushed to other staff. Those staff do not have the clinical skills to interpret what is being asked.
Mm-hmm.
So you don't have a high level clinical person. Now, people talk about working at the level of your license. I would take some LPNs I have worked in who run circles around RNs who can get through that. They know what they know what they don't know. We have RNs who can do the same thing. MAs do not. They can handle some other things quite efficiently, but that's not who's looking through those boxes. That's not who is helping to support that. So because of that, that's also where some of that issue is coming from. Who is seeing what? Who is paying attention to what? How do you know how to interpret the patient's phone call as to keeping them out of the hospital? Again, previous examples we used about COPD, heart failure, etc. And then there's the opposite piece of not the money that is being spent, but the money that wasn't spent that can't be measured because we kept them out of the hospital.
Yep.
So there's those finance pieces of it. It's the high need people on those chronic illnesses that we already have this in writing. We already have this out there. Those are the folks that take up the time and the need, and we do not have the folks to be able to do that
Right.
in primary care. And I think all of us could provide lots of examples of that.
Right. Thank you. Just a quick follow-up for a couple of you, because I mean, really agree. One of the things that came out, and you see this in your daily life, one of the things that came out in the access work a while back was when we talked to the specialty folks, you know, what one of their complaints was, gee, you know, I try to take a patient who's stable on epilepsy medicine and I don't really need to see, and I try to send them back and the doc doesn't have room for them, right? Or, you know, and there are instances where, you know, it's a more complicated illness. The patient may be stable, but it's just not something somebody's comfortable with. Understand that. So it seems that, you know, part of the issue in the primary, and that may again be because there just aren't enough primary care folk, right? Your offices are full, but it is in a sense a chicken and the egg thing, right? If there were a way to get the patient, the stable patient, out of the specialist's office, assuming they didn't want to see him, right? And they didn't say, come see me in a year. Are there any ways to approach that sort of issue when they want to get them back to you? Dr. Merman, please.
Sorry, trying to get off mute.
Yep.
My computer's very slow today. Sorry, you know, actually, if someone else wants to respond to that first, I had sort of a piggyback question, actually, as opposed to a response.
Okay. Well, please then ask a question or make another comment.
Well, I guess my comment is this. So Dave Berman on the Green Mountain Care Board. I think I've met most of you previously in PCAG meetings, and also work as an emergency physician at CVMC, and trying to help Dr. Florence figure out your note situation here on the side. But one of the things that I've been witnessing from my vantage over the last, I would say 3 to 4 years, is a rapid decrease in primary care availability.
Yeah.
And it has been kind of smoldering, and then just recently has just tanked. And that's partially because of retirements in my region, medical illness. But we're at 12 to 18 months is what the case managers tell me for getting a new patient appointment without pulling all the strings in the world. And I also know that this is not just a regional problem. This is a national problem. I think a lot of people are leaving primary care early. Recruiting in has been challenging. And so it's just been making me wonder, you know, we can, and I support increasing reimbursements, pay, salaries, making it a better work environment in Vermont. But, you know, New Hampshire will just make it better the year after. I mean, make the salaries higher year after. I don't think there's a lot more people coming into primary care. That's my point. I think that we're gonna be able to replace who we have, but I don't know if we're ever gonna be full the way we have been. I don't know. I'm just trying to think of, is there other ways that we can help people attain primary care in a more coordinated fashion with the resources we have, making the job better, making the access better, making the, you know, removing the barriers, like you said, with prior authorizations. Like, what can we do to make it so that we have better access with the resources we have, or maybe a small increase over what we have?
Yeah. No, I think your point's right on, right? I mean, because let's face it, even if people doubled primary care salaries or tripled them, and we persuaded a lot of new folk to want to enter training and get to that, we're talking 10 years, right? I mean, that's a long path. And so I think, you know, that is a big part of the issue. And so one of the reasons to have these conversations is certainly to figure out that okay, you're spending a huge amount of time doing stuff that is not necessarily directly related to the medical need. It may be related to social needs or financial needs or requirements. And are there ways to offload that? So that's one of the reasons for being interested, for example, in the community support, community case management groups and that kind of thing, right? If there's not good coordination there, not good help there, if it's making life more difficult and in fact eating time, then that's a potential fix, right? So absolutely take your point. I mean, I guess another question as I think about this, you look at what we all do every day in banking and buying stuff from Amazon and scheduling airplane travel, whatever it is. And a lot of that work, understanding there are a lot of folks that can't do it, but a lot of that work has been moved from the employee of the bank to the person, the customer, if you will. And, you sort of wonder whether there are some things that could be done that way. So one of the things I think about is, the source of all the information we use is the patient, right? We ask a bunch of questions, or somebody does, we put it in some format, and there are ways to have the patient directly enter that. Right, and you actually get better information with branching logic and a well-constructed electronic questionnaire. So there might be some ways to do that. There might be some ways, and I know the EMT system is in disarray, but other places do use emergency medicine techs with advanced training to provide certain services. They did vaccinations in COVID. They can start IVs, not necessarily in really rural areas, but in various places around the country, those folks are used to do some in-home visits. You think about looking for safety in homes and, rugs that are slippery and electrical cords that cause people to trip and that kind of stuff. The Boy Scouts can go in and do a safety survey in a house. I mean, I think there are other ways to approach some of the preventive care, perhaps some of the care which is prescribed or determined by a physician, but doesn't need to necessarily be carried out by a physician's office or a currently available person. So, just trying to think about some of those. We'll come back and test them with you and with others, but I absolutely agree with your point. I mean, there's no cavalry riding over the hill here, right? And that's a real problem. And the other thing I wonder about and would be very interested in the nurse practitioner's view of this. I was married for 40 years to a nurse practitioner who got her master's in nursing at Vanderbilt in 1972. So she was a clinical nurse specialist. And then she retrained in the 1990s as a family nurse practitioner. And after her master's degree, that FNP training, I think, was a year, maybe a year and a half. So it was a short period. And, I looked at the curriculum for the university and the nursing school, and that's certainly consistent with the American Academy of Nursing folk. But that's a DNP track with additional training to get to a nurse practitioner status, which looks like a long time. And so I wonder if there are methods of speeding some of that sort of training up as well. Happy to take screens of outrage.
And I'm happy to take that one on.
Please do. Correct me.
So to go for a DNP directly whether you are already a nurse or direct entry is 3 years, depending upon where you are and if you go full time. It is not the requirement to have a DNP to sit for your national boards and be a nurse practitioner.
Right.
A master's is perfectly acceptable. They're trying to move to a DNP
Right.
as the minimum because of the systems work that goes along with it. And that's part of being in nursing. So you can do it in, up to 3 years. And depending upon where you go, and then people want to do them online as well. And it's buyer beware as to which online schools. Some of them are doing everything 100% online. And as we all know, we don't get to see patients that way. But some of them also are good online programs that have lots of clinical work for you to do. So that's not a blanket yes or no one way or the other.
Sure.
Just like anything else, you can't generalize. So in Vermont, one of the documents that we sent on to you showed the work that could be done in primary care. And in Vermont, in primary care, there's very little that isn't done in the scope of a PA, an APRN, or an MD or DO. So in primary care, those are essentially equivalent, depending upon what you're looking for. In specialty care, depending upon what you're seeing the specialist for, you might see an NP, you might see a PA, you might see a physician, and depending upon what the work is in the specialty care, that can also be equivalent to a degree. In primary care, it's much more global. There are folks who say certain nurse practitioners don't have certain education or training in primary care, or PAs don't. There are physicians who've been trained in everything, but they haven't used it in years and they don't do it. So there are physicians who don't do procedures, certain ones. So in primary care, that's pretty straightforward across the board. To address the previous question, there's a couple of points that linked you started your question with the patient coming out of the hospital and trying to get into primary care, and how do they access and schedule that. That goes back to my other point of the folks doing the scheduling don't know how to do that. So this brings in the third triad of providing care, which is administration. To me, it's the basic triad would be clinicians, IT, and administration. And administration is doing their best with the small amount of money they are given to do something. So they're handing it off to new scheduling folks who know how to use the software to put a patient in a slot. But that doesn't mean that they know that this person who just got discharged with 5 new medications and they're on 20 now, and that needs to go to an RN to evaluate how fast do they need to get moved in, and then explain to the patient you just bumped from tomorrow to next week. And if someone explains that appropriately, they understand, yes, I can wait till next week. You haven't messed up my work schedule. And there is somebody who is sick or who needs to be seen. That requires clinical knowledge. And administration is not necessarily doing that. So you have patients rescheduled or scheduled for very short appointments for acute abdominal pain. But then with something else, they may get a longer appointment. So this comes back to that whole piece of who's doing the scheduling, who's doing the choosing, and who actually has the knowledge of what various roles can do. For example, the health coaches that we have, I've worked with some health coaches where I can hand a patient off to them who has diabetes, hypertension, their medications are managed, they know where they're at, this is the work they need doing. It's the health coach that actually can spend the time with them and get them to make some changes. So we need all the pieces. It's which patients get which pieces and who makes that decision. And because we don't have that clinical knowledge in some of the staff, and because the phone calls or the portal messages or the faxes don't go through people who are sorting with some clinical knowledge, that's where part of the issue is. I'm hoping that makes sense. Amelia didn't shake her head at me.
It does. I was with you. I was nodding along. Eileen and I have also worked in the same area, and the comment you made about how to say things, like I would say, hey, I can't guarantee what I can prescribe this patient, but if they could come in and bring me records, that would be great. Comes out as Dr. Florence won't see you unless you have your records and will not prescribe.
Yeah.
That's not what I said. And I do have a hospitality background, so I mean, I know how to make things sound nice, but it's amazing. I'm like, I literally wrote what you could say and somehow it didn't come out that way.
Yeah. No, thank you. I mean, no, very helpful. And I'll tell you, I've had, we don't have time. So that's a story for another time. Susan's looking at me. We're down to 10 minutes. She's got some stuff she's got to do. Let me again thank each and every one of you. I know it's been a long day and you've been very kind to us and very, very helpful. So I would reiterate, Sam, bring up that last slide so they have the email. You'll have this slide set, but again, my email and Sam's are listed here. It's an Oliver Wyman address, so it does not go to the state. And if you have additional comments or thoughts or suggestions, please send a note. And we've promised to reach back out to a couple of you if there are any others who want to talk or who would like to have a group of people, I'll make it up, concerned with, helping get people with medical needs or social needs leaving confinement, or immigrants, or whatever the population might be. And you would like to help get a group like that together for us to talk to, happy to do it. So again, thank you. We appreciate the time and particularly the information and advice. We will carry forward with this. I can't look you in the eye and say we can fix the problem of the person who answers the phone and whether he knows what he's doing, but we'll try to do what we can and carry your suggestions forward. Thank you. Susan?
I think it's to Julia, who will be talking about public comment. Thank you, Dr. Hamry, and thank you, everyone.
Yeah, thanks, everyone. Yeah, the last item on our agenda is just to see if there's any public comment, since this discussion was just the PCAG members chiming in. So if there is anyone on the call who's not a PCAG member who had something they wanted to say, we can follow the same raise your hand feature. But I know it is 6:52 and maybe anyone who wanted to say anything is in more of a brain fog at this point. So this is just me killing a few moments of time to give people a chance to raise their hands. But Dave.
Can I just add one quick comment to your public comment and to Dr. Hamry's comments about you can send it to him and it doesn't go to the state, but you can also send it to the state. And
yes.
we'd be happy to get any of the thoughts you want to give us that you think could make healthcare better and more accessible and more equitable and all those things. Please, whether it's through the public comment or just emailing Julia or myself or Susan or the whole board, we read it all. We read it all, and it all enters into how we think about things, and so we can't get enough.
Right.
Yeah. Well, seeing that no one has raised their hand, I think in closing, I'll just say that reiterate, we would love for everyone to help promote the community meetings, the provider meetings. Obviously, everything that just got shared was super impactful. I've been getting emails from a couple PCAG members that I just wanted to acknowledge. I'm seeing them, but have tried not to multitask and have not replied to you yet. But of some resources to pass along to Bruce and his team, of some ideas about ways that we can keep giving feedback. So we definitely want to keep that conversation going. And yeah, would love any help you can give us in getting other people, other voices to all of these meetings that we're about to be having over the next few weeks. So Susan, is there any closing words from you? I know we all keep calling on you.
Well, when Bruce was like, and I know Susan has something to say at the end, I said, what do I have to say? Other than thank you, really. This has been fascinating and really impactful. And I think just echo what Dave said, that we want to hear from you, and we will listen. I think Bruce said we won't be able to fix everything. I've been here at the board longer than Dave, so he hasn't had to say that yet, but we certainly will try. So thank you, everyone. And Julia, thank you for putting this meeting together and doing such a great job. And I know Marissa Melamed and Hillary Watson are also on the line. They are the ones leading the project with Julia and me. Marissa just waved, and Hillary is on as well. So you'll have their emails as well. So you'll see lots of, they'll be at all, well, they don't know this yet. We have to work it out. Not every one of the meetings. They need to live a life. So thank you all.
Great. Well,
Thank
thank you,
you.
everyone. I hope people have a
Thank-
great rest of their evenings. We will talk again. Thanks.
Thank you.
Thanks. Have a good night.